Welcome to this evening's webinar on Enterra Therapy. A multidisciplinary approach provides optimism for patients living with gastroparesis. My name is Angela Buffington Johnson, and I will be your host and moderator. Whether you are just starting your gastroparesis practice or wanting to add another therapy option for your patients, we hope that by the end of this webinar, you will have a better understanding of how Enterra Therapy can help. Please submit your questions into the chat and I will make sure to get them all answered. Even if you have to leave early, we will make sure to address your questions via email. It is my pleasure to introduce today's speaker, Dr. Michael Awad, a nationally recognized leader in minimally invasive and foregut surgery. Dr. Awad is a professor of surgery at Washington University in St. Louis, where he directs one of the largest gastroparesis treatment centers in the United States. His expertise in the clinical management of foregut diseases, including gastroparesis, GERD, achalasia, and esophageal diverticula, has made him a sought-after expert in the field. Dr. Awad is a pioneering research in gastric electrical stimulation, with numerous national presentations, book chapters, and peer-reviewed publications on the topic. His recent study, Clinical Outcomes of a Large Prospective Series of Gastric Electrical Stimulation Patients Using a Multidisciplinary Protocol, published in the Journal of American College of Surgeons, has provided critical insights into optimizing patient outcomes with this therapy. Dr. Awad's expertise, research, and dedication to education has made him a leading voice in the field of gastric electrical stimulation. Please welcome Dr. Michael Awad.
Angela, thank you very much for that kind introduction and for the opportunity to speak to everyone tonight. I'd like to welcome all the participants who are joining us this evening online as well. And it is a pleasure to speak to you about a topic very near and dear to my heart that affects so many patients around the country. I'm going to go ahead and bring up my slides here, and we're also going to leave plenty of time for question and answer. So please do put them in the chat, and we'll try to get to all, if not most of them as well. So again, tonight we're going to be speaking about how Enterra Therapy can provide optimism for patients living with gastroparesis, many of whom have been dealing with this for many years and have lost hope. And hopefully we can restore some of that. A couple of notes. The Enterra therapy that we'll be discussing this evening is FDA approved under the humanitarian use device designation. There are several kind of indications and contraindications, and we'll be talking about that through our discussion this evening as well. So we're going to start with just a quick review about what we're talking about in gastroparesis and some strategies with how we diagnose it. We'll be talking about a variety of treatment options that include dietary, medical, and surgical therapy. And then we'll dive into the evidence, particularly around Enterra Therapy, and then talk about our approach to how we treat these patients in a multidisciplinary fashion, which I do believe is the best way to approach gastroparesis. A couple of key points that I want to start with and hopefully leave you with some take-home points. And in our center, gastric electrical stimulation is the first-line therapy for patients with medically refractory gastroparesis. And I'll tell you about my journey there and how we came to that. The other key point with many things in medicine is proper patient selection is key. I cannot overstate this point. And again, we'll talk about how we select our patients for these different options. So again, let's start a little bit, back with what is gastroparesis and how we diagnose it. Just a little bit review of some of the anatomy and physiology. So we know that gastric digestion is a complex physiologic process. It includes a neurologic and physiologic component that's both kind of sensory and mechanical. It's involved by how distended the stomach is or how much volume there is, what's in it, and the contents and mixing of those contents. It involves the emptying of the stomach, both in the antrum as well as the pylorus, and also on the other end, the lower esophageal sphincter and its relationship in this. And When it doesn't work, there are a number of components to this. We know that there are neurologic components that involve the vagal nerves, the splanchnic nerves of the celiac ganglia. There are hormonal interactions with digestion and gastric emptying. There is the fundus is a key part of fundic relaxation, and a number of inputs with gastric dysrhythmias as well. Some of the etiologies are myriad, and this is also really important to think about when we have patients with gastroparesis. We often know about some of the common ones about diabetes, post-surgical, especially esophageal and proximal gastric surgery, especially if they involve the vagus nerve. There are a host of medicines that can affect gastric emptying, and this is a laundry list, and we'll talk about some of the more common ones and emerging ones as well, especially with GLP-1 agonists. And a lot of times it's in this third bucket of idiopathic, meaning we just don't know what causes it. And there are a lot of theories around this with different neurologic conditions, perhaps autoimmune diseases and viral conditions as well. There was a lot of talk about coronavirus inducing gastroparesis, but in short, we just don't know in many cases. The other thing to keep in mind is there are a lot of things that cause nausea and vomiting. And we talked about medications just now, as well as some toxins. There are some central nervous system causes and psychogenic causes that can do that. There are endocrine and metabolic causes, in addition to what we're going to talk about today, which is gastrointestinal causes. So these are, again, a long list of different conditions, but it's really important that we look and evaluate for these things when we treat patients with these symptoms. So specifically now on gastroparesis, how do we define it? And it's really all three of these things. So first is the cardinal symptoms of gastroparesis. And there are 5: nausea, vomiting, abdominal pain, bloating, and early satiety. Those are the 5 key cardinal symptoms. The other really important thing, which I have to state and restate over and over, is it's critical to exclude mechanical obstruction as a cause of the stomach not emptying. These can include, pyloric stenoses or ulcers, masses or tumors in the pylorus or duodenum, SMA syndrome, and other things downstream. Because you can treat all you want with promotility agents and gastric electrical stimulation, but if there's a mechanical cause, that patient will not get better. And then finally, the other component of it is delayed gastric emptying and a demonstration of that. And we'll talk about that. But all three of these together are how we define gastroparesis. So again, we talked about these cardinal symptoms, these 5 things that are listed on the slide here, and in the absence of mechanical obstruction. There are other symptoms these patients might experience, things like heartburn or GERD. If things are not moving in a forward direction, then it will be backed up into the esophagus. And you will see these go along a lot of times. And interestingly, sometimes when gastroparesis improves, GERD symptoms can improve as well. We see a lot of dysregulation in blood sugar levels, and both as a cause and effect of gastroparesis. So when patients aren't eating properly, their blood sugars are going to be out of control. They may have malabsorption of some of their glycemic medicines, lack of appetite, and then eventually weight loss and sometimes weight gain. One of the gold standard still tests that we have today is gastric emptying scintigraphy or gastric emptying studies. And I want to spend a minute talking about this because this is so important for the diagnosis and also eventually for getting therapies approved for patients. So this is a meal of scrambled eggs, toast, and jam that is radio labeled with technetium-99. It's important for those different components because they include carbohydrates, fat, and protein, which all can empty at different rates. So the patient eats the meal, And then this is done in a nuclear medicine suite. They get a baseline exam that shows where the tracer is in their stomach. And then they typically come back after half an hour, 1 hour, 2 hours, and 4 hours and see how much of that tracer has emptied from their stomach. A couple of key points. This must be a 4-hour study, not a 2-hour study, because there are some patients that have a little bit of delayed emptying at 2 hours, but things catch up at 3 and 4 hours. So it must be a 4-hour study. If somebody comes to us with a 2-hour study, we make them repeat it. Also, very, very important, prior to the study, they must be off of medications that slow gastric emptying. Opioids, THC, which is active ingredient in marijuana, and especially now GLP-1 agonists. And we have them stop this for at least 3 weeks prior. This is the current gold standard for assessment of emptying of a solid meal. However, gastric emptying studies, like any tests, are not perfect, and there is some variation in the results. And then finally, insurance does often require this for approving these for many surgical therapies. So now let's pivot to treatment. I want to highlight for you a couple of really nice clinical guidelines. First, by the American College of Gastroenterology, which shows here how we approach and many centers approach this as well. So again, first is patients who present with many of those cardinal symptoms. Again, we want to exclude mechanical obstruction. Typically, we'll do an upper endoscopy and/or contrast-based study. They will get a 4-hour solid phase gastric emptying study. We want to try to remove or minimize the medications that can affect this. If that is positive, that confirms the diagnosis of gastroparesis. And it is very important that we start with more conservative therapies first. So in general, we start with foods that are soft in consistency, smaller, more frequent meals, and easily digestible foods. Things that are low fat and low fiber also are more better for patients with gastroparesis. Then we look at pharmacological options, and these include the cessation of medicines that slow gastric emptying. It includes a trial of prokinetics. Reglan remains, still to this day, metoclopramide, the only FDA-approved medicine for gastroparesis. But there are a number of off-label medicines that are also options that can improve gastric motility. There are antiemetics, all the common things that we know about, dansetron, Phenergan, promethazine, and others, and nutritional support. These can include parenteral and enteral feeds. Enteral is preferred. We really like to work with the primary care providers and gastroenterologists to have patients give a really good try at a number of these therapies, preferably over a 3 to 6 month time period. And only then and when they fail those that we consider surgical therapy. Here's another a great resource, a little more recent from the AGA, American Gastroenterology Association, with a similar algorithm on refractory gastroparesis and their symptoms. And they have kind of an algorithm again for both mild, moderate, and severe cases that include a number of things that we talked about. So again, we start with diet and nutrition. I will say part of, and we'll come back to this in a little bit, part of the workup includes involving a dietitian, if at all possible, to make sure that patients have eliminated things. This graph on the bottom left gives an example of how different types of components can empty from a patient. So you'll see obviously water, liquids empty the quickest from the stomach, but things that are high fat empty much slower and a high calorie as well. So again, dietitian can be very, very important. We talked about pharmacologic therapy, also looking at comorbidities. Patients who have very poor glycemic control are going to be very hard to manage from a gastroparesis standpoint as well. So sometimes that involves getting an endocrinologist as well involved in their care. The other thing that I'd like to think about is also on the other end of the GI tract. And so if about a third of patients with gastroparesis also suffer from refractory constipation. And if things aren't moving from the bottom end, they're not going to move very well from the top end as well. So again, involving a gastroenterologist with things that can help with constipation, pro-motility agents like prucalopride or Motegrity can help with that. I even have had some patients with colonic inertia that I will have a colorectal surgeon manage, maybe up to and including a colectomy before I'll go for surgical therapy for their gastroparesis. And then we're going to dive into a lot of the surgical options here as well shortly. I would like to spend time talking about the Enterra device, which is a gastric electrical stimulation. This device, as I mentioned, is considered a humanitarian use device by the FDA, and it is approved for treating chronic intractable drug refractory nausea and vomiting secondary to gastroparesis, diabetic or idiopathic etiology, specifically in adults up to age 70. And this is a picture of what it looks like. It involves a couple of components. One is the gastric neurostimulator itself. That's a device that's implantable underneath the subcutaneous pocket in the skin. The other component is the two leads or electrodes that come from the device, and they're placed at a specific spot in the stomach, which we'll go to later. Those leads are in the muscularis wall of the stomach. And the third component is a programmer that is used in the operating room or in an outpatient setting to adjust settings with radio frequency signals on the device itself. So those are the three components of the Enterra. So let's look into this in a little bit more detail. And based on early preclinical studies, it was determined that the ideal spot for the leads is precisely 10 centimeters proximal to the pylorus. The leads are placed perpendicular to the axis of the stomach. They are placed 1 centimeter apart. So one is technically 9.5 centimeters, one is 10.5 centimeters proximal to the pylorus. The other part is when we place the leads, the business end of the lead needs to be within that muscularis layer of the stomach wall. So it can't be under the serosa, and of course it can't be showing anywhere in the mucosa. So specifically, it's got to be in that muscularis layer. When we implant this, and I'll show you a video here in a second, we do confirm that the leads are in the right place by checking with the programmer that we have good readings, and we also check endoscopically during surgery to make sure those leads haven't penetrated the mucosa. These procedures are pretty quick. It takes about an hour. I personally prefer the surgical robot to place the leads just because of the precision it affords and the control, but there are centers that do it with conventional laparoscopy as well. So here's a video. So I typically use the suture to measure 10 centimeters proximal to the pylorus. I will typically just use 3 robotic ports. We're going to place one of the leads. There are these kind of ski needles that allow you to facilitate placement of the leads. The needles, again, are placed perpendicular to the long axis of the stomach. And again, the first lead is 9.5, the second lead 10.5 centimeters perpendicularly. So we use that ski needle to tunnel through the muscularis layer. We want to go at least 1 centimeter and sometimes more. That helps to, and then we pull the ski needle through, and that helps to make sure that exposed middle part of the lead is completely buried within the muscularis layer. And we do the same for the second lead. Again, 1 centimeter apart, parallel to each other. at least a centimeter tunneling. And we do not secure the leads just yet. We're going to check the lead um, functioning in two ways. One, we're going to attach those leads to the programmer and make sure that it is getting good readings. And secondly, we're going to do endoscopy to make sure that the mucosa has not been penetrated. Once we confirm that, then we can secure the leads to the stomach wall. The device itself is, I extend one of the laparoscopic ports and I place the generator in a subcutaneous pocket in the anterior abdominal wall. So how does the Enterra device work? Well, there are a number of thoughts. One has to do with gastric accommodation and capacity. It's believed to work on the interstitial cells of Cajal, which we know are the critical for the gastric electrical stimulation or dysrhythmias of the stomach. There's a thought of a mechanism with both vagal afferent and efferent nerves, as well as brainstem structures that the Enterra can work on. Just a note, it is not considered a pacemaker in that it doesn't apply signals at kind of the pacing rhythm of the stomach. Now, the big question is, does it work? In short, the answer is yes, but there's a lot of studies that lead us to the answer. In fact, there have been over 50 peer-reviewed studies in the literature over the last 10 years, and you can actually see the number of studies is actually increasing over that time period. 4 of these studies are randomized double-blinded trials, which we'll touch upon here today. But this is one of the most actively studied and evidence-proved devices that we have for gastroparesis. So we'll start with 2 studies that were done in 2010 and 2013 in the United States for treating diabetic and idiopathic etiologies, respectively, in 2010 and 2013. And they were really elegant studies. These are prospective, multi-center, double-blinded studies in which the patients and the providers, the implanting providers, didn't know what the settings were. Patients were randomized to first, after the device was implanted, it was turned on for 6 weeks, and then patients were randomized to have the device turned on or left on or turned off for 3 months. And then it was crossed over with 3 months off and 3 months on. And then finally, all patients were turned on. So there were 6 in the diabetic and 8 in the idiopathic studies. The primary endpoint was looking at vomiting frequency in this particular study, and these were several secondary outcomes that were looked at as well. So the results were quite striking, and you can see in both groups, both the diabetic and the idiopathic gastroparetics, a 68% and 87% respective reduction in nausea symptoms at sustained at a 12-month period. And this was statistically significant in both groups. And in both groups as well, in the same trials, diabetic and idiopathic gastroparesis, you also see a significant reduction in the number of hospitalization days. At 1 year, 75% reduction in the diabetic group, and essentially 100% reduction in the idiopathic group. They similarly looked at total symptom severity scores, and again, we see significant reduction in those scores as well, in both groups. Another more recent study was done in 2020 in France, and again, a really nice, elegant, randomized controlled trial looking at gastric electrical stimulation therapy for drug refractory vomiting. And again, this was multi-center, double-blinded. They had, after surgery, they actually had the device off, and then they randomized patients to 4 months on, 4 months off, and measured vomiting scores and quality of life scores. So this is the scale that they used with regard to symptom improvement and the frequency on the left. There was 172 patients, so it's a large study involving 19 centers. So a very well-powered study. And you can see here, both in diabetics and non-diabetics, the improvement in scores with patients that had the device on compared to those that have had it off. Again, statistically significant in both groups. And then this looked at long-term improvement now with gastric electrical stimulation. So we know about the short-term outcomes, but this group, also in France, looked at least 10 years data. So this was remarkable for the length of the study. This was published just a couple years ago. And again, this was retrospective in a single study, but they followed at least 50 patients out that had outcomes or tracking at least 10 years after their gastric stimulator was implanted. And they followed them uh, for these symptom quality of life index scores that they talked about, with the primary outcome, again, being reduction in nausea and vomiting. So in this study, they found that the quality of life at 10 years out was still sustained in these patients, which was statistically significant. 80% of patients rated that they had overall satisfaction with their Enterra device still out at 10 years, which was quite remarkable to hear that. So again, the data is quite prominent. And again, there's many, many other studies, but I wanted to focus on those. And we'll pivot now and talk about what we do in our own center. And again, I'm at Washington University in St. Louis, and a lot of credit to the multidisciplinary team that I have the privilege of working with that involves gastroenterologists, dietitians, behavioral therapists, endocrinologists, and others. So again, and psychologists as well. So we make sure that they know it's a team-based approach, that our patients know that as well. So I just want to reiterate a couple things. First, we have to eliminate or exclude mechanical causes, so everybody gets an upper endoscopy and then some sort of imaging, like an upper GI series or a CT scan with oral contrast. Presuming there's no mechanical cause identified, every patient gets a 4-hour solid phase gastric emptying study off of all opioids, THC containing products, and now GLP-1 agonists for at least 3 weeks. And I know this can be hard as some patients are on chronic opioids, for example. But we actually try to work with pain management service to see if we can reduce or even eliminate the narcotics with non-narcotic analgesics. And we find that actually a lot of patients, when they stop those, their gastroparesis goes away or their gastric emptying studies normalize. So I can't, again, overstate how important this is. And then we prefer to see 6 months of monitored medical management. That includes that dietary and behavioral modification that they've tried, that soft, more frequent, smaller meals, a low fiber, low fat diet. We talked about the medications. I'd like to see that patients have tried at least 2 prokinetics and 2 antiemetics. Now, sometimes they may have contraindications due to neurologic side effects, issues around cardiac dysrhythmias and QT intervals. But we like to see at least a good college try with those medications. And patients need to be nicotine-free. Then and only then do we consider them surgical candidates. And I talk to patients about all surgical options. Now, in our practice, based on the evidence that we've collected over the last 16 years, Enterra gastric electrical stimulation is our first-line therapy for patients who are medically refractory gastroparesis. And my own practice has evolved over time. This is, I used to use more pylorus relaxing procedures earlier in my practice, but based on our data as well as that of other centers, this has become our first-line therapy. Some important things, though, when I see patients in clinic that I talk to them about. Number one, it is not an instant fix. because of the need to adjust the settings over a period of some time, most patients take about 4 to 6 months of adjustments to reach that peak level of therapy. So this is really important to set clear expectations for the patients and also for referring providers that it's not going to instantly turn around their gastroparesis. So it's really important to set that clear expectation up front. The other thing is that compliance is really important. This is not a set it and forget it kind of treatment therapy. So for patients in whom compliance is a concern or they won't be able to be compliant, I tell them that the Enterra therapy may not be the best choice for them. Another thing to know about it, there is a battery inside the generator. The battery lasts about 5 to 7 years, depending on the settings for most people. And that even after we get to a good level of therapy, I do like to see them back, especially as we get closer to that 5 to 7 year time period, at least once a year. That way we can check on the battery status and replace it before it completely loses its energy. So that way they don't have a gap in their gastroparesis relief. It is MRI conditional. It is now recently approved for MRIs of the head and the extremities, not yet approved for MRIs of the torso. Of course, the device is made of metal, so I ask patients if they have any metal allergies to nickel or jewelry or other things. If there is a concern for that, sometimes we'll actually do allergy testing. Again, it is not approved in patients who are pregnant and or expecting to become pregnant in the near future, and also patients who are pediatric or over greater than 70 years old. The other thing that I find really important to tell our patients and to our referring providers is that, I will continue to work on the surgical side of things. However, we still need to involve the whole team for optimal therapy. So I still want to keep their gastroenterologist close involved in the therapy as as the Enterra device therapy kicks in, a lot of their gastroparesis medicines and sometimes their GERD medicines can be reduced or even eliminated. I like to keep their primary care physicians involved, their endocrinologists, dietitians, and others. So again, team-based approach is key for optimal therapy for these patients. So this is a study that we had the privilege of publishing a few months ago in the Journal of the American College of Surgeons, in which we published our outcome of the gastric electrical stimulation over a long period of time. Early on in my practice, I wanted to start studying my outcomes. And so I kept a prospective IRB approved database of all my foregut patients, including my gastroparesis patients. In this particular study, because I wanted to follow our study patients that had at least 5-year follow-up, we included patients from 2012 to the present. In this group, about 157 gastric electrical stimulation patients had at least 5-year follow-up. So these are the baseline demographics. You'll see here in those 157 patients, most of them about 45 years old, about 60% of them were females. BMI was about 25. You'll see that about a third of them had previous opioid use, like I say, previous, because we do require they stop it. About a third of patients are diabetic, 60% are idiopathic, and then a number of other causes, including postoperative. Every patient has to have had a delayed gastric emptying on their gastric emptying study with a mean of 28% retained at 4 hours. So here's now our first look at the data, and I'll walk you through this graph. So we use what's called the GCSI, or Gastroparesis Cardinal Symptom Index score. And this is a nationally validated patient-reported outcome measured tool to look at gastroparesis. It involves three subscales: nausea and vomiting, postprandial fullness, and bloating. And you can see within those each of the kind of the line items there. So again, the scale goes from a high numbers are worse, lower numbers are better. So in our study, in the preoperative group, you can see here patients having numbers around kind of 3 and 4, so indicating high values in that preoperative group, as we'd expect. 1 year after the Enterra device is placed, we had about 141 patients follow up. And in that group, their numbers range from 0.9 to 1.5. So a significant improvement in the GCSI at 1 year. And we were excited to see that this was sustained even 5 years out with GCSI scores of 1 to 1.7. We looked at a number of other outcome measures that included medication use, hospitalizations, both in number and in time, and more importantly, were they satisfied with their gastroparesis symptom relief? And we won't go through these number by number, but again, you'll see here medication use significantly reduced, hospitalizations have gone down, and 87 and 80% of patients respectively were satisfied with their gastroparesis symptom relief at 1 year and 5 years. So again, really, really excited to see this and hopefully making a dent in what has been a very challenging diagnosis to treat. What about the impact, not just to patients, but about our healthcare system? And so again, we looked at the hospitalizations, and I want to take a moment to talk about this in particular. So on the left-hand side, you'll see here, these are the percent of patients that were hospitalized for gastroparesis in our study. In the pre-op period, 58% of them were hospitalized. 1 year out and 5 years out, this went down to 13% and 14.5%. The number of hospitalizations in the past year also went down after patients received the Enterra device. So if you look cumulatively at the number and duration of hospitalizations, you'll see that what we calculated here was 303 hospitalization events down to 27 hospitalization events at 1 year after the Enterra therapy. So 91% reduction in hospitalizations, which again is remarkable thinking about what kind of impact this has on our healthcare system and our society, not to mention our patients. So I'd like to wrap up with a number of take-home points. First, gastroparesis is multifactorial and, very importantly, requires a multidisciplinary approach to improve symptoms. Surgical intervention is reserved for those that fail dietary, behavioral, and medical management. And again, proper selection is key. I can't overstate this. But for properly selected patients, Enterra gastric electrical stimulation can provide significant and sustainable symptom relief. With that, I thank you for the opportunity to present this evening. This is my email address, and I welcome direct outreach if folks have questions about gastroparesis centers, multidisciplinary treatment, the Enterra device itself, or how we do the procedure. So with that, Angela, thank you again. I'll hand it back over to you and see if we have any questions.
Yes, thank you, Dr. Awad, for taking us on this journey through your comprehensive approach to providing care for patients living with gastroparesis. We have received several questions in the chat, so let me go ahead and pull that up. First question, tell us about the concept of the tell us how the concept of the trial came together and why you and the Washington University team felt it was important to run this trial.
Yeah, thank you. Like I said, I always think data is key. We all have our opinions, but that's all they are, our own opinions. And so, we want to provide evidence for things that we're doing. clinically, whether it's Enterra Therapy or otherwise. So early in my practice, I committed to developing a database. It was started off as an IRB approved Excel spreadsheet, and it's kind of grown since then. But I tracked our outcomes for our foregut patients, my gastroparesis patients, and my Enterra Therapy patients specifically. And after many years, I was really excited anecdotally to see the impact that it had on these patients, but I wanted to quantify that. So we analyzed our data, and this is where I was really excited to see the impacts it was having on their symptoms, the hospitalizations, costs of care, and so forth. And we wanted to get that word out there and publish that last year.
Thank you for that. We're seeing some questions come in around the programming settings used in the study.
Mhm.
Could you share with us how the patients were programmed and why did you take this approach?
Sure, yeah. And for those less familiar with the Enterra gastric stimulator, there are a number of settings that you can adjust on the device itself. That includes the current of therapy that's provided. It includes how long it fires for and how often it fires for. So the duration of firing and the interval of firing, the frequency of the current, and some other settings. So when I implant the device in the operating room, I turn it on at what's called nominal settings. So that's 5 milliamps of current. It's on for 0.1 seconds, off for 5 seconds. And so it fires every 5 seconds, whether the patient's awake or asleep, eating or not eating. Because we know gastroparetics have symptoms throughout the nights, in the morning, even when they're not eating. So that's the implant settings, what's called nominal. And then I see them back 1 month postoperatively where I start adjusting their settings. Most people are just only going to have minimal change in their symptoms at that point, so they will likely need an adjustment. At that point, I start increasing the current. And I turn up the current typically by about 5 milliamps at a time to a maximum of about 15 milliamps. I don't go much higher than that because I don't find there's a lot much benefit beyond 15 milliamps. Then I do start adjusting the duration of firing. So instead of 0.1 seconds, I'll go to a half second. The next adjustment, I'll go to 1 second, and then 2, and then 3. Similarly, when I adjust the duration of firing, I also increase the frequency. So instead of every 5 seconds, I'll do every 4, every 3, and then every 2. There is a lot of interest in what is the best protocol for ramping up patients, how fast we can do that. And there's a lot of active interest and research going on in those protocols right now.
Thank you. Again, moving along, we have some questions specific to gastric emptying test. First one, how do you address diagnostic testing with a gastric emptying test for a patient that has an egg allergy?
Yeah, that's a great question. There are actually egg substitutes that specifically are for those patients. So most of the nuclear medicine centers that do this can offer patients a non-egg substitute.
And then similarly, how do you approach this diagnostic study for patients with previous gastric bypass surgeries, got either got gastric bypass or a gastric sleeve?
Yeah, also excellent question. I think it's really important in a post-gastric bypass patient that have these symptoms, nausea and vomiting, abdominal pain, bloating, early satiety, to really get at the bottom of what the cause is, because a gastric bypass itself is an excellent treatment for gastroparesis. Remember, we're excluding most of the problem organ, that is the stomach, from the enteral circuit. So most of the stomach is not seeing food. And so we really have to first ask, is gastroparesis truly their diagnosis, or is there something going on? I find in most patients, it's actually something else going on that needs to be investigated. So a gastric emptying study, as other studies, is not the best test in gastric bypass patients. We're probably looking for other things. An upper endoscopy and upper GI series are still going to be important for evaluating those patients.
Wonderful. The next question asks what your approach is for patients with BMI of 35 plus or
Mhm.
greater with gastroparesis who either do not want bariatric surgery or are otherwise not good candidates for it? And would you still offer GES?
Yeah, again, excellent question. And so when I see patients who are medically refractory, I try to look at the whole picture, and that is what therapy is best for them as a whole. Um, if they are otherwise candidates for gastric bypass surgery because of excess weight and a BMI of 40 or 35 with comorbidities, I do talk to them about that option. Now, while I myself don't do gastric bypass, I will offer them a referral to our bariatric center because not only may that help their gastroparesis, but it may help their other comorbidities of hypertension, hypercholesterolemia, cardiac issues, diabetes, and other things as well. If for some reason they're not a candidate for gastric bypass or they otherwise elect not to, then yes, I will offer them an Enterra device. And they often are just respond just as well to that as other non-bariatric patients.
Okay. We are seeing some questions in the chat related to cessation of opioids, THC, and GLP-1 agonists. You mentioned that your monitored medical management includes cessation. How long do you keep your patients off these offending medications before moving forward with Enterra therapy?
Yes. So the first time point is the diagnostic time. So we make sure that they're off of all of those for at least 3 weeks prior to the gastric emptying study. And then if we find that it's abnormal and they've gone through their kind of 6 months of dietary and medical management, and we find they're surgical candidates, again, we work very hard with the other team members to get them off of all of those agents. And most times we're successful. It, again, it involves a multidisciplinary team, pain management, and other team members as well. I will say the GLP-1 agonists, while they certainly do have their benefit for properly selected patients, it has introduced a new wrinkle in the gastroparesis world. I'll have many patients that have gastroparesis that are on GLP-1 agonists. I've even had patients that I've placed Enterra devices in that have had a great result, and then somebody, perhaps not, innocently puts them on a GLP-1 agonist, not realizing what its mechanism of action is. And the patients then go back months or years in their therapy and have rip-roaring recurrence of gastroparesis symptoms. So it is very, very important to watch out for those medicines.
Another related question to that, we have someone who has started, who has shared that it seems that many patients referred are not narcotic dependent by the time they get referred, and that it is really difficult to get them off. Do
Mhm.
you not offer Enterra if unable to get them off the narcotics?
Yeah. Again, a great question. And to me, the very first thing I try to do is diagnose them, uh, uh, that is their gastric emptying study off of narcotics. And that, again, is hard, but at least that's a shorter time period, that 3-week window. And I do get pain management involved because I know that can be difficult. But that's so important to me because there are many patients in whom, if you stop their opioids, their gastroparesis goes away, and they may never need surgical therapy. So at least try to have them do that. If for some reason they need to resume narcotics, I understand that that could be needed for a certain population of patients. We still work with them to minimize that, but if there is some minimum amount that they need, I will still offer gastric electrical stimulation.
Thank you for offering that. There are some questions in the chat around whether you would ever add simultaneous pyloromyotomy and pyloroplasty when placing the Enterra gastric stimulator.
Yeah, also great questions coming through the chat. So I will say earlier in my practice, I used to do a lot of pylorus relaxing procedures. First, laparoscopic pyloroplasty, and after we got experience with POEM, endoscopic pyloromyotomies, or so-called G-POEMs. And we did a lot of those, hundreds. Um, they work okay, but like in our studies, we showed that almost 90% of patients have significant improvement with the Enterra device. Whereas in our study, as well as in many other high volume centers that do GPOMs or pyloroplasty, about 40% of patients at best get benefit, and the improvement in gastric emptying is pretty marginal. Most of those patients still have abnormal gastric emptying. So I've kind of personally shied away from a lot of the pylorus relaxing therapies. I only reserve that now for patients who are not a candidate for the Enterra device because they have metal allergies, they can't be compliant, they need MRIs for some reason. I think there is a lot of interest in whether the combination therapy may provide an additive or synergistic effect. Those studies are ongoing, and I think the jury's still out on that.
All right. As someone building a gastroparesis program, how do you incorporate behavioral health psychology into your practice, and how do you get your department of psychiatry or psychology involved with these patients?
Yeah, again, another great question. And I will say a lot of our program was modeled after bariatric centers, which involve again a multidisciplinary team of gastroenterologists, nutritionists, dietitians, behavioral therapists, and so forth. So we use that model to develop our own center with similar benefit and outcomes. I think it's really just, I made an appointment with those individuals. I sat down with them. I shared with them our experience. I shared with them, what these patients are going through and how difficult this can be, but also my hope and optimism and excitement for what I saw them um, going through after gastric electrical stimulation, and really partnering with them has been so key. So I didn't have to drag them, to the table with this. They were very excited to kind of partner with us on this program. And similarly for gastroenterologists who find, that they may be at the end of the rope as far as medical therapy and are really looking for another option for their patients. I really like being able to offer that option. I like to keep those gastroenterologists close in that patient's care, even after the Enterra therapy is placed. So definitely building the team is key.
Thank you. That makes sense for sure. The next question in the chat asks whether you do any routine blood work for nausea and vomiting to rule out any other causes.
Great question. For me personally, I don't do any kind of specialized blood work unless there's something kind of other symptoms that are out of the ordinary besides the kind of typical cardinal symptoms for gastroparesis. So, we do just the usual kind of preoperative blood work testing. They obviously can't have coagulopathy and those things, but if there are other suspicions, especially downstream GI tract conditions, we do cast a wider net, but in general, just the standard preoperative blood work.
There's a question around whether there is specific criteria with regards to the pyloric function that must be met for Enterra. So when would you choose a therapy specific to pylorus versus Enterra?
Yeah. Again, also great question. And, we still don't have a great way today of assessing kind of underlying pyloric function. Again, we want to rule out mechanical causes of pyloric obstruction, such as with upper endoscopy and or contrast studies. But barring any true mechanical issue with the pylorus, which the vast majority of patients with gastroparesis do not have, there is no gold standard for assessing the pyloric physiologic function. There have been a lot of interest in our center and in other centers of using tools like functional luminal imaging probes, what's called FLIP technology, to measure the pylorus. But it wasn't designed for that, and it typically is not very sensitive or specific for disorders of the pylorus. Similarly, in patients with pylorus relaxing procedures, it too is not a reliable method of measuring its adequacy or success. So we don't really have a great way of measuring pyloric function, but unlike in achalasia, where the lower esophageal sphincter is the root problem, in most patients with gastroparesis, the pylorus is not the problem. It's the gastric body and the antrum that's the issue.
Okay, that's helpful. Thank you. Coming back to your study, you shared the trial design and patient enrollment criteria for your study. Can you please share why it was designed this way and what factors you took into account in your design?
Yeah, so basically, in our database, we included all patients that were candidates for the Enterra device based on kind of the parameters that I listed there. Um, uh, we wanted to make sure we followed patients long term, so we have placed more Enterra devices than that, but I wanted to make sure to include patients that had had it for at least 5 years so we could assess their long-term outcomes. I wish I had follow-up for every single one of them. We are being in the Midwest, we have a 5 hour approximate catchment area. So sometimes it can be hard to catch people that are far and away, but we do still try to. So we were pleased we had most patients follow up, but not quite everybody. But primarily, at least patients that had it 5 years that met those diagnostic criteria were eligible in our study.
Thank you. All right, I think we have time for two more questions. The first one is, how do you place the leads when patients have a G-tube?
Hmm. Yeah, again, great question, and that can be a challenge. You know, if possible, when we communicate with a gastroenterologist or perhaps a surgeon who is thinking about a G-tube, if a patient is a near candidate for Enterra therapy, we prefer that a G-tube not be placed because yes, it can be in the way. Having said that, sometimes that's just not an option. A patient has come to us already with the G-tube placed, and we understand that. That can make surgery a little bit more challenging. Um, Many times the G-tube is not at that 10 centimeter proximal to the pylorus location. And the stomach anatomy may be tented up to the intra-abdominal wall because of the G-tube, but we can still kind of follow it back from the pylorus on that intra wall. There are a few times when that G-tube, just by dumb luck, is right at that 10 centimeter point, in which I'll have to put the leads in a different spot and I will move it slightly to be away from the G-tube, both to not interfere with the G-tube, not puncture it when I place the leads, but also hopefully that G-tube will be discontinued at some point. I don't want the leads to be affected. So yeah, there have been, I can probably count on one hand, even just a couple of times, how many times that's happened, but it can happen.
Thank you. And the last question, you mentioned during your talk that continued interaction with GI, PCP, and endocrinology is important. When working with that extended team, what information makes your care coordination more effective and efficient?
Yeah, again, and I've said this a couple times, and I know I sound like a broken record, but the care team, the dietitian is so important, again, to help patients recognize what is a gastroparesis friendly diet. The endocrinologists are extremely helpful in regulating blood sugar. As I mentioned, patients with poor glycemic control, it's kind of a tug of war with the Enterra therapy where we're trying to adjust the settings, but the sugars don't work. And it goes in reverse. As the Enterra therapy kicks in, their glycemic control may improve and some of their medicines may need to be adjusted as well. The gastroenterologists, we may find that some of their prokinetics and antiemetics can be reduced or even eliminated when the Enterra therapy kicks in. And I prefer to involve them in that decision making. So, we don't have too many, conflicting decisions on medical therapy. So everybody has a role in that team. And again, building that is really, really important.
Thank you very much,
So
Dr.
before
Awad.
we part, I did put my email again in the chat, or sorry, I think I put that for the hosts and panelists, or no, I think it's for everyone. So hopefully you can see my email there, and I welcome outreach. If folks have additional questions we didn't get to or would like to talk about a potential Enterra therapy program for their institution.
Wonderful. Well, thank you, Dr. Awad. This was a very helpful and educational webinar. And also we have one last slide. that you, for our listeners, you can continue your journey, your learning journey here by scanning the QR code to download the full manuscript. And then you can also scan the QR code to the right to learn more about patient selection for Enterra Therapy. Until next time, thank you again, Dr. Awad, and thank you all for joining us.
Thank you.